I think that I want to add one more aspect of probably a profound learning for Alex with his experience was that laughter is the best medicine unless, of course, you're treating diarrhea. So I want to share a little bit with you today about new perspectives for me, changing perspectives. As I got interested in design and innovation, that was catalyzed early on when I made a catastrophic medical error on a 7-year-old child pre-op early in my career. I was working in a small 35-bed hospital, and that's if you counted the sofas in the waiting room, things like that. It was 35 beds. Very small hospital, and we had about 42 patients that night. We had some in the hallway, and I was preparing to leave from a night shift. We had a 19-year-old LPN working with me that night, and I heard the intercom come on, and it was our surgeon. I'd worked with him long enough to know that his voice was ominous. He said, "Laura, I don't know what you gave this little girl down here, this 7-year-old child, but Laura, we're losing her. She's not breathing. What did you do?" Everybody that takes care of patients just lives in horror or fear of that moment that you're going to get that page, you're going to get that call, that you made some mistake, and it came so early for me. So I went over to the intercom, and I went over, I couldn't believe what I heard. Felt like I was going to throw up, pass out. Went over to the medication area and looked down and realized immediately that I'd given her 10 times the overdose of scopolamine. Now, for those of you that know scopolamine, that's seizures, coma, and death. And so I began to understand that this child's life was hanging in the balance. Never prayed harder in my life, and by the grace of God, by whatever forces of the universe, that child survived my care that night, but boy, just barely. And I thought, how in the world could this happen? Because I grew up passionate. I knew what I wanted to do. I was one of those kids that loved recess, not for the reasons that the other kids love recess. I loved recess because there was a higher chance of injury. And then I could sort of swoop in and, care for the person and, bandages and things like that. And so recess for me was just, this was my time. So I'm thinking, how does this happen that I almost kill a child this early in my career when I was born to do this? And I understood then later when I started tracking that the fact that when that medication order had arrived in my hands, it had been hand transcribed 6 times before I'd gotten to it. Hand transcribed 6 times, really? When it can be death by decimal point? This is the design of our system, and I realized there was no design. It lacked design. It was that somebody said, oh, we ought to have a Cardex. Okay, well, great, well, then we ought to have a medication administration record. Well, let's break that out by shift and have 2 or 3 of these. And by that time, you realize that there wasn't any possible way. This was an accident waiting to happen. I don't care if Florence Nightingale was on that night. She'd had the same propensity for error that I had that night. I wanted to see and understand system design. Well, it's just so much worse than I thought as I began to look at things in a more global way. And the 2 things I want you to look at here is that we, out of our $2.3 trillion, $2.6 trillion, we waste 1.2 of it. I can assure you we do. We waste that through hospitalizations that don't have to happen if we would properly coordinate care. If we would properly activate patients, they wouldn't end up in our emergency room seeking care. If we would make sure that things like people have the capacity in their own homes to put an electronic scale in that lets us know when they've gained 2 pounds in 7 days, we can adjust their medication, they can be home with their families on Friday night instead of drowning in their own fluids in our ED. These are the kinds of things I consider waste. Waste of that happiness potential, waste of so much potential, waste of dollars. The other thing we can look at here is, this is something that Alex told me, I just couldn't believe it. Our current healthcare system is the #1 contributor to sickness and death in the US. Knowing that I contributed to that, I understand that. I ran hospitals in New Orleans for a while. We also made a medication error there that took the life of a 14-year-old child. I also understand how the system design affected that. I can assure you I'm intensely motivated to make a difference in all of this. There are 2 things wrong with our healthcare system, the way it's paid for and the way care is delivered, the way we even define care, as you can see what Alex talked about. The problem with our financing system is that we've been the only industry for a very long period of time that could inflict a defect on our customer and then bill you to fix it. So if we didn't wash our hands and you got an infection, dang, things happen, defects happen, but we could also bill you to mop up after that infection. Well, we've just recently been told by society that that's going to stop, that they're no longer going to pay for infections when we don't wash our hands, because Michigan has showed us that you can get down to no ventilator-associated pneumonias. You can get down to no central line infections if you really pay attention to system and design, and you really think about what it's like to have that infection as a patient. So the second thing about our challenge here is that it's the system, along with the payment, is that when we think about, I'm not talking about people deliberately making errors, deliberately being wasteful, deliberately doing these things. I think bad systems bring out the worst in good people, and how I know that is when I ran hospitals in New Orleans, the first thing I would do is come in the morning and say, oh, the census is up? Yes, excellent. You know, I'd pray for a bad flu season so that we could keep those beds full. And then I think, how did I get to here? How did I get to cheering illness and infirmity? What brought that out in me? I think it had a lot to do with the payment system. So now I'm absolutely thrilled to see that we have, you can argue all you want about the reform bill, ACOs, these types of things. There's a baby in that bathwater, and that baby is payment reform in that reform bill, and I want to be sure that at least in terms of Obamacare, that portion at least preserves, because I think it's extremely important for us to get out of the mindset and the sort of structures that we have built around the idea that we can create defects and bill people to fix them. So these are exciting. Now, providers, can they survive under this new payment system? Can they really survive if their goal is to produce health? If their goal is to produce health, I actually don't think so, because we have come and get it care. That child with asthma, we see you when you come to our ED, when you come to our doctor's office. We need to be thinking about, are we connecting with your school? Are we connecting with the Boys and Girls Clubs? Do we have asthmophilus so that we can begin to understand where in our communities we're seeing triggers for asthma, because we're crowdsourcing that data that's coming to us? I don't see how we're going to succeed under new payment systems if we don't understand how to engage the community and how to understand that it isn't about engaging people in the healthcare system, it's about engaging in their lives. When you think about this as our foundation for information sharing still across the country, you try to understand how that group of patients is doing. It'll take a graduate student about $3 million in a couple of years to understand our performance. And it's really easy for us not to have the truth told about our performance, including to ourselves, when that's the system. This is what happens when we try to share information across boundaries. This is sticky notes, this is faxes, this is the garbled voicemail that was left, this is the thing that was supposed to be mailed but wasn't mailed, because we don't have this inability to share information. The other thing that's causing a barrier there, no good deed goes unpunished, ACOs. I sent a chill down my spine when I first saw that somebody sent out a message over the wire saying, we get this ACO thing. We are forming a private health information exchange within our ACO so that we can keep the data. The data is power. And I'm thinking, my God, you so missed the point. You so missed the point. The idea of an ACO is to be able to provide that information, that data for that patient, no matter where they need that care. If they have their car accident outside of your ACO, we need the information over there. There's been so much talk about getting patients permission to share information across boundaries electronically. I'm thinking if you're planning on hoarding it, you better get permission from the patients, because that's really what puts them in danger, not the sharing, it's the hoarding of information. So when we look at that, there's brand new barriers there that weren't there the first time when I developed this slide. When we think about that challenge, you also understand that primary care providers need to interact with 229 physicians and 117 different practices in order to care for their panel of patients. And we do most of that by phone, by carrier pigeon, by mail. We really have to understand how to build out this foundation for communication. The sad thing we also learned from McGinnis's research, and I think is just becoming clear to us, and this is what Alex is trying to tell us, that in terms of the proportional contribution to preventing premature death, our healthcare system is only about 10%, $2.6 trillion and 10% effect. We really have to understand, how are we going to affect the behavior? Look at that piece of the pie that's behavioral. That's the aspect of engaging in patients' lives, learning how to support, learning how to understand what strengthens that patient and causes them to see themselves as the picture of health, even with chronic disease. So with our current system, what are the chances of succeeding under these new payment models? When we think we need to activate the community, we need to understand what health really looks like. I'm pretty sure that this is how most of us are feeling about now. How can we possibly move these metrics? How can we possibly get people to health when all we know is how to treat disease and come and get it care? So I want to talk a little bit about, this is my son, Ben, and I just love that kid so much. We're happy in this picture because there are two things we don't know. The first thing that we don't know is that this was taken last fall. The Patriots are going to go on, and they're going to be in the Super Bowl, only to lose in the Super Bowl. So this was sort of a pre-Super Bowl lost picture. The other thing that we don't know is that there's a cancer growing in my right breast. I wish that pictures could point out something like that, because that was taken about a month before I went for a routine physical, and my physician said, hey, what's that? And I said, gee, that would be my right breast. And he said, no, I'm talking about that lump. What lump? Wow. So I was just absolutely convinced. I went to my neighborhood hospital to get my mammograms done, and I just thought, well, it's a cyst. And he said, I think it's a cyst. So I said, yeah, we'll go in. And by the time they brought me back for about 6 different views, I was getting worried when they laid me back on the table to do an ultrasound. I'm a clinician. I knew when he was moving that Doppler over that lump, and he wasn't telling me, hey, it's fluid-filled, we're good, that it wasn't good. I looked up and I could see the reflection of the monitor on his face, and I knew that he didn't want to tell me what he was seeing. And so I said, you're not talking to me. And he said, I'll tell you everything I see in a few minutes. I knew right then and there. He did a biopsy at the same time and said, Laura, you're going to get a diagnosis of breast cancer in the morning when this biopsy comes back. And so I called my mom, and I just said, I couldn't say it. I just said, Mom, I didn't dodge the bullet. She said, what? I said, I went for the mammogram today. I didn't dodge the bullet, Mom. And so then I had the really painful task of breaking the news to my then 12-year-old son. So I'm looking at this and thinking, what sorts of things am I going to learn out of this? The first thing Ben, my son, said was, Mom, I feel so guilty because I'm excited that Grandma's coming, so when you go to the doctor, I live in Boston, so I have access to all these fabulous resources. When you go to doctor on Monday, Grandma's going to be here to be with you to find out how bad this is, but I'm kind of excited that she's coming. I said, Ben, let's start a silver linings list. Let's start a list of all the awesome things that have come out of this diagnosis, and let's start it right now. That list is about 5 pages long. There was nothing that created more happiness in our life as a result of my breast cancer than that silver linings list. I mean, it's got everything on it from, he said, well, gee, I think Dad's going to take us to legal seafoods tonight. Can we put that on the list? I said, yeah, we can put that on the list. And then the list for me, there were profound things on it, like I'm really going to understand the world I'm trying to change, because my life now depends on this healthcare system. It literally depends on it functioning. So I was quite excited about the possibilities and the opportunities here. And then there were some good things on the silver linings list, like I realized I had the chance, if I really wanted to, I could get double Ds. You could see I didn't go for it, but I thought the insurance company would even pay for it. I did consider it for a brief period of time. And then, the other thing that was just marvelous out of it was the threshold for looking good was just so low. As soon as people saw me after the surgery and I was breathing, they were just like, you look fabulous. And thinking, I got sweats on, I have no makeup, this is great. So there were so many things on the silver linings list that brought joy to my son and to me through this period of time. And I knew that that was what Alex was talking about. I know Alex, I love Alex. He's been teaching me for a very long period of time. I knew this was what he meant. So if I wasn't already convinced about what I needed to do to change, my little community hospital said, you need to go into the Mecca in Boston. We can't help you with this. You need to go in there. And by the way, here's all your x-rays. You'll have to take them by hand. What? This is Boston, right? I'm carrying these by hand, right? So here's all of your mammograms. And by the way, this little disc right here is that MRI that was just so horrific that you went through. And they really need this one to be able to diagnose. I said, oh, okay, right. Boy, okay, Mom's coming in. I gotta worry about these. We go to the facility, and we're in the parking garage, and I'm trying to get collected and making sure that I've got all my stuff with me. And I turn around and I said, Mom, the disc is gone. I don't know where the disc is. She starts frantically looking and realizes we both at the same time see it under the back wheel of my car in the parking garage. It had fallen out. And I'm thinking, for God's sake, I cannot get organized around hauling my stupid records from point A to point B as I'm going in to find out what the rest of my life might look like. It could be shortened. I can't be organized. I've got to take care of my mother and of my son. So the next thing that happened was they had to look at the left breast and decide, does she have cancer in that? That took stereotactic biopsies, that took all kinds of things all the way up to and including surgery. As they put me to sleep for that, I remembered that advance directive was very important to me. I can tell you that I work in medical error every day, so I'm highly aware of that. I wanted to be sure somebody had an advance directive on hand, so I dutifully copied it, put it in my purse, brought it to the hospital, and then I was sucked into the system. Before I knew it, all my things were taken away, and next, here we go. And as they start to put the anesthesia mask over my face, I realize, oh my God, my advance directive. It's folded up in my purse, it's locked in a cubby, and nobody knows where it is. I want a system, an electronic system, where I can upload that advance directive, because you know as well as I do that every one of those advance directives that we have right now, 80% of them are sitting underneath a magnet on Aunt Sadie's refrigerator. They are not where we need them when we need them, because we do not have a longitudinal record of care that crosses proprietary boundaries. This is the experiment we're running in Rhode Island. We're one of Alex's living laboratories, and I can tell you we're just incredibly excited about the idea of bringing together that kind of database that does not respect competitive types of things, that respects the patient first. So no news is good news. I had a sentinel node biopsy, and I was told that it would be about 10 days before I would find out, was there cancer coursing through the rest of my body? Anxiously awaited that. And in the course of waiting for that, the 10 days came and went, and 2 weeks came around. And so I sat down with my son and my mother, and I said, I know this is really hard, but I think I have to take one for the team here. I think I have to experience this as if I were a non-English speaking patient, a patient who couldn't have made one phone call and been in at the top of cancer care in Boston because I'm in the system, somebody that was just a regular patient. I think I have to go. We lasted 3 weeks, and then I couldn't put my son through it anymore, and I couldn't put my mother through it anymore. So I called my oncologist and said, somebody at this facility knows whether or not cancer's in the rest of my body. I'd like to know too. And she said, oh, you're good. You can't imagine how many times I thought about that moment that I was going to get a yes, it's positive, and there's problem, or no. I thought through it. I had no idea that the chief emotion I was going to have was anger at the moment. I felt so uncared for at the moment. She said, yeah, let me take a look. Oh, you know, it's been back for about 11 days. I thought, no, those weren't 11 days. Those were 11 sleepless nights that you put all of us through for that. Why didn't someone care enough to do that? Now, I want an app that immediately tells me, your test is back. Even if it doesn't show me my test, then I want somebody to notify me the moment that test is back so I can make that phone call. That's the kind of healthcare design that we make when we see it through the patient's and family's eyes. And then I went in after my mastectomy, and I'm feeling really good. I'm thinking, okay, I lost a boob, no big deal. You know, they reconstructed it, looks pretty good, you know, so I'm pretty happy. And, but I go in and I talk to my team now about, I'm worried. I'd like to figure out, can you help me with all the ways that I can make sure the cancer never happens again to me? I was thinking they were going to talk to me about diet and how to be in the moment and really begin to understand how to control stress, how to exercise better, all these things. And they said, oh, you know, this is probably not going to happen to you again. Don't worry about it. And you know what? If it does, we'll just take the other one off. What? Just take the other one off? I kind of like it. I'd sort of like to keep it, if you don't mind. And it dawned on me then that the system was unable to support me in my next step toward wellness. It was simply unable to support me in that. Alex, that's exactly what we're talking about. The system failed that. I needed a better system to take care of me when I was sick and a better system to help me when I was focusing on health and wellness. So information flow today in Rhode Island, we've created this centralized system in Rhode Island where we're connecting up every hospital, every long-term care facility, every doctor's office. This is going to be a long journey, but we are way ahead of the game here. We've got the top leaders, CEOs from all the major hospital systems. Every single insurance CEO sits on our board. We've got on our board strong patient advocates. We've got people from business community. We've got the state government there. It's everybody with their hands on the levers of Rhode Island healthcare system. We can change a law in one session if we need to. We see the governor 3 times a week in Rhode Island. It's 35 miles by 45 miles, 1 million people, 3,000 doctors, 13 hospitals. Perfect test bed. If we can't do it there, I think we should be slapped. I really do. It's just the perfect test bed. So the statewide health information exchange, you can get these slides. There's all kinds of things we're doing with that. It isn't just getting information from point A to point B. We now can tell alerts. We now can tell a primary care doctor as soon as their patient hits any one of our EDs or is hospitalized, we can send a note to them. We can also let them know when that patient is discharged. They can begin the coordination of care across proprietary boundaries. This is any hospital your patient goes to. Because we built this health information exchange, we pull in ADT feeds from all of these hospitals, and that's how we're we're able to do that. We can do a detect and notify. You do an OxyContin prescription for this patient. If you'd like to be, us to be detecting and notifying the next time that patient gets an OxyContin prescription, whatever pharmacy, we can do that. It's that kind of thing that when we start thinking about why we would build something through the eyes of the patient, it looks so much different than somebody's proprietary health information exchange with a moat around the data, which I cannot understand. So this platform for innovation, we're also beginning to build this capacity for us to talk about the metrics. Just how well are we performing? We haven't been in the habit of telling the truth about our performance. We are assuming the best in ourselves and not measuring. We're almost always disappointed. I can remember bringing out this information for the first time, and I'm putting up the information there, and I can see that my group of physicians, and they're sort of not happy with me, and I'm thinking, look out among the audience, and I think, you know, I'm among friends. They're just not my friends, certainly not at the moment. So, person and community supplied data is essential because people are already in control of their health care. They're already in control. So we prescribe the pill for them. They can take it home. They can break it in half. They can feed it to the dog. They can take it. They can not take it. They can combine it with another pill. This idea that we are somehow in control of the patient's care is just such an illusion. And as soon as we can get past that idea of that illusion, I can think that we can design so much more powerful systems. So the other concept here is that this come and get it care, engaging in their lives. So as you're designing innovations, thinking about it from that aspect, get as close as you can to the people who are affected by your innovations. And then it is going to take a village. We talked about the fact that I want to be able to make sure that that scale that that patient steps on with congestive heart failure is hooked up to my health information exchange, so I can have something detecting and monitoring when that patient gains that 7 pounds over those 2 days, and then I can shoot an email through a secure system to whatever provider needs to know, so that that care manager can get on the phone with that patient, and again, we can keep them home with their family on Friday night. But we only need one connection in Rhode Island. Every doctor doesn't have to interface with every awesome app, with every type of, we can do that one time through the health information exchange, and that information then becomes part of that patient's longitudinal record, part of the data that they upload every day when they're using their asthma inhaler with the Asthmopolis app or the Asthmopolis sensor on the top. So we brought together a whole bunch of amazing people to figure out how to activate our community. We were in Silicon Valley in Cordoval, and we used Alex's organizing definition from the World Health Organization to begin to think differently about how would we organize and activate our community if we really want health, not health care, because health care now has to produce health. So we wanted to become this living laboratory. We joined Alex's group of people around the world, able to speak to others, able to get ideas. I'm headed to Bogota next month. I'm so excited to be able to exchange ideas and understand what are they doing, what are we doing, how's it going for us. We had people like Seth Goldenberg who kicked off that meeting. We had Alex there. We had Beth Comstock from GE, $3 billion innovation fund. We had people like Denise Young-Smith who design and run the Apple stores. We wanted to ask Denise questions like, what if we designed a patient-centered medical home on the principles that you designed the Apple store? What would it look like if we designed it in that way? Those are the kinds of conversations we want to catalyze in this living laboratory. And so I'm just going to end by saying that if there's anything that I could encourage you to do as a result of my talk today, it's think about that innovation through the eyes of the patient. Think about the impact that it's going to have. Think about how to connect it to the rest of the people in your community. Think about how to connect it to what that patient interfaces with on a daily basis. So if you have a health information exchange, start talking to them about what about the data. We were thinking of, at this fantastic meeting in Cordoval, we were thinking about, you know, telomeres are the only modifiable part of the DNA, and they respond most to lifestyle things. That 40% on the pie diagram of behavioral stuff. What if we measured everyone's telomeres in Rhode Island, loaded it up into our health information exchange, and then did things like maybe a public summertime screening of forks over knives in the park? What if we did things like take those blighted factories in Olneyville that are just eyesores and lights on the community and make agroponics happen all up and down that farmer's market on the bottom floor, sell those vegetables to people that have no access to those fruits and vegetables that are native to their homelands. I mean, we could think of remarkable things to do when we got that group of people together. That's what happens at this forum here at Transform, and why I was so excited to come for my first time. I felt fortunate enough to speak. So what I'd like to do is just leave you with a quote from Don Berwick that has been a guiding light for me. It was one thing to harm a patient, and then to have the harm inflicted on me and my son. I had to be vigilant at every move. At one point, I looked at the computer that they were checking me in on the Friday before my mastectomy, and they really weren't interested in me seeing the screen, but I happened to get behind to have an EKG, and I could peek over the shoulder, and I looked at the screen. I felt like Elaine on Seinfeld, you know, being the difficult patient, and I look over the shoulder, and I realized that they've got me on the surgery schedule for a double mastectomy. And I said, is that me? Is that my chart? She said, yes, that's your chart. I said, I'm not having a double mastectomy. She said, yes, you are. No, I'm not. And so we got my surgeon on the phone, but I know how these errors happen. It's stuff like that. Somebody way back when they were doing the stereotactic biopsies on the other side decided to hold a double mastectomy on the surgery schedule in case we needed it. It never got changed. Involve people in their care. They'll make the care safer. I could make that mistake not happen by looking at that screen. So Don Berwick's quote is, he said that, I've heard it said by cynics that the quality of medical care would be far better and the hazards far fewer if we, like pilots, were passengers on our own airplanes. I want to assure you that if you don't have somebody that you love in the healthcare system right now, your father, mother, son, brother, daughter, you will. And so not only are we passengers in our own airplanes, so are they. Thank you so much for the opportunity. Appreciate it.
First, for some of you who are standing in the back, there are seats down here, so please, we welcome you to come on down. There's plenty of places to sit, very comfortable places to sit right down here in the front. Take a breath. Wow.
I think that's the first one I've taken, a little lightheaded, actually, so I speak really quickly.
So much to think about there. You say patients are already managing their care, yes, in your experience. Now, is the expertise you want to draw from them, their ability to deal with the same chaos that you were talking about in the system and trying to organize their healthcare information and make informed choices and try to keep the system from sort of running them over, I guess, is part of the issue. What expertise do those patients have, aside from their self-interest, that we need to marshal and learn from in some way?
I think that in some ways they have an insight that healthcare and hospitals, for example, can be very dangerous places to be. They don't actually want to be there. So I think they harbor some understanding about how to keep themselves out of that, if we can enable that. I was trying to do that after my breast cancer. What can I do? To be told that we could just come back in and take the other one off was not the answer. So I think what I'm asking is that we understand that here at the moment I was most activated to get out there and figure out how to change my lifestyle, reduce stress. We miss the moment. We miss the magical moment. People will come in and they'll be so ready for us to enable them. If they could have just passed me on to, here's somebody who can give you this information, boy, this is a terrific website. Here, we've got a whole booklet that we've prepared for patients like you that are now ready to make sure that this type of thing doesn't happen again. By the way, when you do change your diet, it's going to help you with, have any blood pressure issues, it'll help with that. By the way, your joints hurt, it's going to help with that. These are all things that changed for me after I started eating vegetables. I don't need reading glasses anymore. I'm 56 years old. Who doesn't need reading glasses at 56? I don't. It's that idea of activating people, because we have this innate wisdom about our own bodies. We are the expert in our own bodies. I think that it's developing a respect for that and understanding that they do know what makes them happy. They do know where they can access that source of strength, find out where that is and enable it.
So they're hungry for information, they're
yes,
good information users and gatherers, and we want to maybe not have them be so responsible for the safety net of the system. We don't want that vigilance and fear of the system to get in the way of their information gathering resources.
That's right.
All right, that's great. How do we scale up your successes in Rhode Island to something larger than a nice, adorable little state like Rhode Island?
Yeah, one of the theories that we've used in Rhode Island is the diffusion of innovations theory from Everett Rogers. We base our work there largely on complex adaptive systems theory and diffusions theory. So I'm thinking that any organization, any region, any community that wanted to talk about what we did, we understood who the opinion leaders were in our community, and we amassed them. The bylaws of my organization says there's a few things here. We're going to move the needle on metrics here. We're not here to write another white paper. We're here to make things better. Secondly, cooperation. We understand all you people are natural enemies in the wild, but you're going to work here together. You're going to collaborate. And then the third one was don't send your lieutenants. So those of you that are CEOs and you're coming around the table in 2001, 6 months from now, we don't want your assistant director of landscaping in your place. We want you. So we understood that theory of diffusion of innovations, and we began to get those opinion leaders, getting them in the room. And then we lined the room with the public because we made our board meetings open. So I'm not saying that people would not have acted honorably and would not have made better decisions, but when your behavior is public, it's just amazing how that transforms the types of things. Nobody would suggest hoarding data in the state of Rhode Island. You wouldn't last. You just wouldn't do that in that sort of a milieu. So there are certain principles of the way we designed it that I think are extremely transferable.
And so that built-in accountability thing makes it as sustainable. People are on the record to basically pursue this, so once they start down the road, they can't get off it. Is that the idea?
And there are consumers all around you, people who are involved in the healthcare system holding us accountable for the things that we're saying and doing. And you think twice about saying something that is, once again, a preservation of the old system that's designed around the provider versus moving into the new system.
How's the silver linings list? Is that growing or shrinking?
Oh, we love the silver linings list. It grows all the time. I have to say that when my son's soccer games last fall, all these parents were out and it was like 40-degree weather and they were all shivering and shaking, and I'm saying, I got another biopsy next week. Yeah, I'm going to sit in the car. This is great. We put all kinds of things on that list, and my son and I now go back over and we look at those things, and there are more and more profound things. I can tell you I spoke for Alex at the University of Toronto in June, and the title of my topic was Thriving After Cancer, not in spite of cancer, but because of cancer. I'm at the point now that I got so much good out of this. When I review that silver linings list, if somebody asked me if I would go back and just erase that episode from my life and just go on living, or would I have cancer, I'm just about this close to saying I'd have it all over again because something had to get my attention.
One last thing. Did possibility of double D ever make it onto the list?
It's still on there. Yeah, I'm thinking if at some point there's ever an exchange that's in my future, it could happen.
Laura, thanks so much.